Dr. Maha Badawi. Dr. Maha has obtained her medical degree from King Abdulaziz University in Jeddah in Saudi Arabia. Then she completed all of her postgraduate training in internal medicine, followed by clinical hematology, followed by transfusion medicine at University of British Columbia in Canada, and she returned in 2014. Currently, she is holding the position of the Director of Blood Transfusion Services at King Abdulaziz University Hospital, and she has many research interests, including hemoglobinopathy, transfusion medicine, and donor recruitment, blood utilization. This session will be, some kind of testing the knowledge of transfusion medicine. So I'm assuming that it will be a semi-interactive session. So the floor is for Dr. Maha. Thank you.
Thank you, Dr. Mohammed. I'm really pleased to be among you today, and I'm very grateful to the organizing committee for inviting me to be part of this beautiful event. This talk is going to be completely interactive. I will need your help and interaction with me during this. So I will show you my first slide. It's basically, it's a group of questions. I need you to go to this website. Okay, I know some of you are watching from your phones, but if you can, go to this website. It's called menti.com. Menti.com. I am not sharing my screen yet. That's funny. 1 second. Okay. Okay, so I hope you can see my screen now. On top of the screen, you can find the name of the website. It's called menti.com, and then you will be guided to a screen where you have to type this code. So this is what the screen will look like. I hope you can see it. So this is the screen, and on the bottom you will find a space to type this code, and the code is 60256532. So the website is menti.com, MENTI.com, and the code is 60256532. And the code will be visible on every single slide. So I hope that that helps. So just to make sure that all of you are with me in this, this is my first question. Where are you right now? What city are you currently in? Excellent. So we're getting some answers. Your answer will immediately pop on the screen. So I'm looking for like 20, 30 answers before we move on. Excellent. So we have lots of friends from Riyadh, Al-Qasim, Jeddah, Hafuf, Al-Taif, Al-Ahsa, mashallah. So again, the website, it's called menti.com, and the code is 60256532. Excellent. Dawadmi, Qatif, mashallah. That's the beauty of online events. We can meet from all over the world with very little expenses. Okay, so we have a good number of people who were able to got in the website, and I hope you, all of you, even if you cannot get in right now, you can participate in later questions. So this was only my first question. It's definitely not related to transfusion medicine, but just to get you familiar with the program. So this is my first question. I'm starting with very, very simple questions. Not all of the questions are simple. So this is our first question. Now you should be able to see this question on your screen. What is the minimum acceptable hemoglobin for male blood donors? So the options are 12, 12.5, 13, and 13.5. Excellent. So, okay. So I'm gonna stop here. So the majority of you decided that is 13, and that's actually the correct answer. So this has been the answer for a while now, for a number of years, and it continues to be the correct answer. So the correct answer is 13. 13 is the minimum acceptable hemoglobin for male blood donors, which is corresponds to hematocrit of 39%, while for females it's 12.5, and corresponding to a hematocrit of 38%. So that was the simple question. Okay, so here is another question. You get a blood donor with positive testing for anti-cardiolipin antibody. So that that donor had this test done as a patient. Now he's donating blood, and one of these tests on this list will be falsely positive. So is it going to be testing for HIV or syphilis or babesia or HTLV1 and 2? I love how this shows the results in real life. Okay, so we have a good number of answers, and the correct answer is, in fact, the syphilis non-treponemal test. So the trick here is the word non-treponemal. Syphilis has a number of different tests. Some of them are treponemal and specific, while some are not as specific, which are the non-treponemal tests. And among non-treponemal tests, the reagents contain the cardiolipin substance. So the reagents do contain this substance, and it might explain a false positive result on an non-treponemal syphilis testing. And definitely further testing is recommended to complete counseling of the donor and deciding if this infection is confirmed. So let's move on to another question. According to the most recent recommendations from the United States FDA and the AABB, what is the deferral period that is currently recommended after a donor gets a tattoo? Is it 3 months or 6 months or 12 months or 18 months? So now I'm referring to the most recent recommendations. Those are the recommendations that were put on by the FDA after COVID-19. So we have all sorts of answers. Okay, so the majority of you did not get this question correctly. The correct answer is, in fact, 3 months, which is shocking. If you still think that the correct answer is 12 months, which is the way it used to be. That's the way it used to be before COVID-19. After COVID-19, the FDA decided to revise all of its recommendations in regards to donor screening and acceptability criteria, and decided that 12 months was extremely precautionary and that 3 months were adequate in that regard. And the statement now reads, defer for 3 months from the most recent tattoo, ear or body piercing, an individual who had a history of a tattoo, ear or body piercing. However, they have another exit. You can actually accept them earlier with no deferral if they got the tattoo by a state-regulated entity with sterile needles and non-reused ink. Individuals who have undergone ear or body piercing within 3 months of donation are eligible to donate without deferral if the piercing was done using single-use equipment. So for us in Saudi Arabia, we have to wait for further recommendations from the Ministry of Health and regulatory bodies before we implement this change. However, it is coming. This is the QR code. If you want to read the whole recommendation, you can go to the website of the FDA and read the whole recommendations. This is a QR code to make it easier for you to get there. Okay, so I'm now going to ask you a question about post-freezing RBCs. So red cells can be frozen for those of you who are not exposed to frozen red cells, because that's not a routine practice. So red cells can be frozen if they were rare, and they can be frozen up to 10 years using glycerol with a concentration of 20 to 40% at temperatures that range between -65 to -120. After we thaw these red cells, glycerol has to be removed, okay? So glycerol has to be washed out of the red cell. And the question is why? Why do we need to remove the glycerol from frozen red cells after thawing? Is it because it causes anaphylaxis? Does it cause hemolysis, thrombocytopenia, or is it nephrotoxic? Okay, so the majority of the responses come as it's nephrotoxic. We're still going to get some more responses. I'll wait for a few more. Okay, so the correct answer is in fact hemolysis. So glycerol causes hemolysis because it has a different tonicity from blood. So it is not known that it is nephrotoxic, and it's not documented that it causes anaphylaxis or causes thrombocytopenia. The most important side effect is hemolysis, and that's why it has to be removed from frozen red cells. Okay, so this is an important question if you have pathogen inactivation technologies in your blood bank. It definitely adds a lot of safety to our processes, but it does not act on all pathogens. So which of the following pathogens cannot be inactivated using pathogen reduction technologies? And you have hepatitis C as an option, Trypanosoma cruzi, MERS-CoV, and hepatitis, bacterial spores. And I put this question here just to remind ourselves, the blood supply will never be 100% safe or free of infections. And that's why we have to use the patient blood management principles as described by Dr. Ahmed just before this lecture, because the risk will never be zero. Okay, so that's a very interesting distribution of answers. And there are a number of pathogens that cannot be inactivated using pathogen reduction technologies. On this list, the correct answer is, in fact, bacterial spores, which most of you picked at this point. MERS-CoV, we have good literature from Saudi Arabia by our teacher, Professor Hindawi, about inactivation of MERS-CoV using pathogen reduction technologies. And there is a good literature about hepatitis C and Trypanosoma cruzi inactivation. So there are a number of pathogens that are not, may not be completely eliminated or inactivated using pathogen reduction technologies. And these include hepatitis A, hepatitis E, parvovirus, prions, and bacterial spores. So keep those in mind whenever you are thinking about risks of infections, even from bacterial pathogen inactivated platelets, for example. Okay, so you have a number of blood components. Which of them need to be irradiated? Which of them should definitely be irradiated? Is it apheresis platelets, whole blood, granulocytes, or I think I had stem cells as the third option, fourth option. So which one would you pick? Which one definitely needs to be irradiated? Okay, so we have a good number of responses here, and okay, we have a changing scene here. So the correct answer is in fact granulocytes. You definitely do not want to irradiate stem cells. They will lose their effectiveness. Whole blood itself, just because it's whole blood, is not a reason to for irradiation. However, for whole blood and for apheresis platelets, it really depends on the recipient. So let's take a closer look at this. So irradiation of blood component is indicated, has a single use, a single benefit. It's one of the few things in the blood bank where we say the benefit of this is only prevention of transfusion-associated graft versus host disease. And it has a number of indications. It's definitely indicated when the transfusion recipient is immunocompromised. So if you're giving whole blood or apheresis platelets to an immunocompromised patient, then yes, you need to irradiate those. But if the patient is immunocompetent, then there is really no need, just because it's apheresis platelets. It is indicated with HLA similar components. So if your patient is platelet refractory and you got those platelets from an HLA matched donor, then those platelets, yes, they need to be irradiated because the HLA is similar between the donor and the patient. And it is indicated with all granulocyte components. So just reminding you, this is a board review. So you might not see all of these in your real life, and that's okay, but they can come in questions. Okay, which of these is a reason for a permanent deferral of a donor? So if a donor comes in, they have West Nile virus or had Lyme disease or Babesia or CMV, what would be a reason to say, sorry, you can never donate in the future? Okay. How many minutes do we have, Dr. Mohammed?
We do have another 5 minutes.
Okay. But whenever time is up, we can just stop because we are very flexible in that way. So the correct answer, we're getting answers all over the options, and the correct answer is in fact babesiosis. So if the donor had a history of babesiosis, they can never ever donate in the future. In regards to the other infections, and I understand these are not very common infections in our part of the world, but we need to know them. So for Lyme disease and for CMV, both donors can donate after they become asymptomatic. Babesiosis results in permanent deferral, and for West Nile virus, the recommendation is 120 days after diagnosis or 120 days after symptom onset, whichever later. Okay, TRIM. This question is about TRIM, transfusion-related immune modulation. Transfusion-related immune modulation is a complication of transfusion which was described over the past number of years, and it is thought to explain one of these statements is correct. So I just need you to pick up the correct statement. Does it result in does transfusion cause reduction in graft rejection after kidney transplant, or does it result in a reduction in the rates of post-operative infections, or are transfusions associated with an increase in negative spontaneous miscarriages, or cancer? Does it result in a reduction in tumor recurrence? And most of you picked the right answer. So yes, it was noted in patients post-kidney transplant. Those who were transfused more had lower rates of rejection, suggesting that transfusion might be associated with an immune suppression effect. So basically, let's just talk about TRIM for a second. So TRIM, or transfusion-related immune modulation, we think that transfusion is a liquid allogeneic transplant causing changes to the immunological profile of the recipient. And such changes could be pro-inflammatory or immunosuppressive, and the immunosuppressive effect is clearly visible in the effect in kidney transplant recipients. Transfusion is associated with an increase in tumor recurrence and is associated with an increase in risk of infections during hospitalization. It is associated with a reduction in the risk of spontaneous miscarriages. So let's take one question before we stop. Okay, so in 2019, new definitions were published for TRALI, describing TRALI type 1 and TRALI type 2. And my question here is about the main differences. What are the differences between TRALI type 1 and TRALI type 2 according to the 2019 published definitions? Is it the time of onset after transfusion, or is it the presence of ARDS risk factors, or is it the degree of hypoxemia, or is it, I can't see all the options, but you can see them. Findings. So let me talk about TRALI for a second. So until we had the Canadian Consensus Conference definitions from 2004 for TRALI, and we were following these for a very long time. And then the critical care community changed their acute lung injury definitions. There is no longer in critical care literature, there is nothing called acute lung injury. Now it's mild ARDS, okay? And based on that, based on all the literature that was published on TRALI. A new paper was published in 2019 attempting to redefine TRALI or improve the definition that was already there. So previously we had TRALI and we had possible TRALI. Now we don't have anything called possible TRALI. We have TRALI and we have TRALI type 1 and TRALI type 2. And you picked, well, we have a tie. The difference between TRALI type 1 and type 2 is the presence or absence of ARDS risk factors. So I'm going to just show you the new definitions. So TRALI, basically, it has to be of acute onset. There has to be evidence of hypoxemia, bilateral pulmonary edema on imaging, no evidence of left atrial hypertension or volume overload. And it has to occur during the transfusion or within 6 hours of the transfusion. For type 1, patients must have no risk factors for ARDS, and there has to be no temporal relationship to an alternative risk factor for ARDS. While type 2 are patients who have risk factors for ARDS or had mild ARDS but deteriorated in relation to the transfusion. And in order to confirm that they were, this is temporarily associated with the transfusion, they needed to have a stable respiratory status in the 12 hours before the transfusion. So it's interesting to see how these new definitions will help us during our clinical work as we see these cases reported in order to be able to define which is which. Shall we take another question, Dr. Muhammad, or is time up?
Well, actually, the time is up.
Time's up, okay.
But because you don't have questions after your talk, talk is actually questions, you may take another 2 minutes.
Okay, we'll just take one question. So this is my last question. So thank you for the generosity. This is my last question. So as you know, in patients undergoing therapeutic plasma exchange, we have the option of choosing the replacement fluid. So we either use albumin or plasma or normal saline. The question is, in which of these 4 diagnoses would you prescribe FFP as the replacement fluid of choice? And I know I did not put TTP on there because TTP would be the very obvious answer. There is another diagnosis on this list where FFP is the replacement fluid of choice according to the ASFA guidelines of 2019. So yes, most of you picked the right answer, and the correct answer is in fact catastrophic antiphospholipid antibody syndrome. And this was one of the major changes, for me at least, in 2019 version of the ASFA guidelines. They recognized that in addition to removal of the antibodies in catastrophic antiphospholipid antibody syndrome, you really have to replace the natural anticoagulants, protein C and protein S and others. And that's why FFP now is the replacement fluid of choice for patients undergoing therapeutic plasma exchange. And that concludes my slides. And I'm really grateful for being interactive. And thank you so much.
Okay, thank you for this great interactive session, Dr. Maha. And I think we all shared the fun of having the questions and answering them. And such sessions usually people don't get enough of them because they're the interactive ones that really keep you thrilled all the way.